be the pulmonary artery denervation for pulmonary hypertension secondary to left heart failure. So first of all, I will invite my colleague Dr. Zhang Juan to introduce the patient history. Go ahead, Dr. Zhang Juan.
This is a 71-year-old male. He was presented at emergency department because of he was suffered from repeated chest distress for 5 years and aggravated for half a month. And he has hypertension for almost 10 years and elevated fasting glucose for 10 days. And he has already received the CRTD implantation for 2 years. And he has a history of smoking and alcohol drinking for almost 30 years. And the physical examination on admission revealed that there was few most serious in the lungs and cardiac enlargement and moderate edema in lower limbs. The laboratory examination after admission shows that the patient has renal dysfunction and his eGFR is only 32 milliliter per minute, and his BNP is remarkably elevated. The ECG and Holter show that the patient is a sinus arrhythmia, and the Holter discovered that he has the ventricular perimeter contraction and ventricular tachycardia. The CAG coronary artery gradient for this patient reveals that the patient's coronary artery is normal. There is no atherosclerotic lesion or stenosis or congenital anomalies. This is RHC waveforms for this patient. Furthermore, right heart catheterization results finds that actually the patient is CPCPH with elevated PA pressure is about 44 millimeter of mercury, and the PAWP is also elevated. The PVR is almost 6 Wods. After the heart team consultation, the final diagnosis for this patient is dilated cardiomyopathy and heart failure and NYHA class 4 heart rate, and with pulmonary hypertension, CPCPH, and hypertension, and coronary kidney disease. The medical therapy for this patient is strictly applied to the GDMT with metoprolol, dapagliflozin, and ANI, and diuretics. This is the imaginations of echocardiography of this patient. From the transthoracic lung axis view, we actually can see the dilated LA and LV, and LV is the systolic function is decreased, and there is also mild to moderate pericardial effusion. And there is a mitral regurgitation, at least moderate, and mild to moderate aortic regurgitation. The etiology of the mitral regurgitation due to is the tethering of the mitral valves, and we can see the restrictive movement of the posterior leaflet. And this is a peristernal thorax view of the left ventricle. From these views, we can see the global reduced movement of the airway. And this is the apical four-chamber view. And from these views, we can see the both right and the left chambers dilated, severe airway dysfunction, and moderate to severe mitral regurgitation. And the movement of the airway wall is quite decreased. And the airway EF measured by the 3D measurement is only 34%. And the EDV and ESV is also increased dilated. This is a measurement of the E over E prime. The E over E prime is remarkable elevated, is about 22. It is, as we all know, the value is strictly compliant to the PCWP. So we conclude that the patient's feeling pressure is quite high, and the GL is only 5.9. This is the value of the echo measurements. Above of all, we give the final diagnosis. The patient is dilated cardiomyopathy and dilated at left and right side chambers with airway global hyperkinetic wall motion and airway systolic severe dysfunction with increased airway filling pressure. And there is moderate to severe functional mitral regurgitation combined with mild functional tricuspid regurgitation and pulmonary hypertension, pericardial effusion. That's all, Prof. This is all information for this patient. Thanks.
So I will backward a little bit to see how to define the procedure of pulmonary artery denervation, PADN. So very clearly, the patient has a long history of heart failure. Cardiac echo confirmed the significant reduction of the left ventricular ejection fraction. I think now you can see the angiography for pulmonary artery using the large lung sheath. So the sheath tip is just above the level of pulmonary valve, directly forward to the ostium of left branch. So usually we need to use two projections. One is the epicranial, the remaining one is the aero cranial. Both are very shallow projection. That means only 20 degree for cranial, also 20 degree for LLO. After pulmonary artery denervation, I think these are very important injection to confirm the bifurcation area between left and right branch, and it will be very useful to guide the ablation site. So usually, according to our animal study and autopsy, so usually the main trunk of pulmonary artery sympathetics localized at the left lateral wall is a neural nose hub on the left lateral wall of main trunk of pulmonary artery, and the nervous trunk will bifurcate just at the distal bifurcation level, with one around the anterior to posterior wall of left branch, and another one localized at the posterior wall of right branch. Dr. Zhang, can you show the epicranial angiography? So this is the epicranial angiography to confirm the lung sheath tip is very close to the orifice of left branch. Also, before the procedure, I think my colleague Dr. Zhang Juan has introduced there is no any finding of PE pulmonary embolism by CTA. Right now, you can see when we have finished the angiography for pulmonary artery, so it's very clearly to see the spinous cancer is just in the main trunk of pulmonary artery, right? So, camera, can you see the pressure line? If you can see, so now how much is the systolic pressure is above the 70. The diastolic pressure is around 30 to 35, with a mean pressure of 47. So it's a very significant increase to the pulmonary arterial pressure. How much is the PCWP? It's 21, right? So
yes.
where is the radial artery pressure line? Once we have finished the measurement of the pulmonary arterial pressure, so I think it will be a little bit difficult. You know, basically we tried to use this Van case to engage the distal pulmonary artery, but because the right atrium is pretty big, so it's very, very difficult to get this Van case in. So instead, we use the pigtail to put in the left ventricle to measure the left ventricle. So 47 minus 20, 23. So it should be 24. How much is the CO? How much is CO?
4.3.
4 pounds. How much is the PVR?
6.28.
Okay. So now we have finished the measurement of the hemodynamic. Mean pulmonary arterial pressure is 47. PCWP is 23. So the difference between mean pulmonary arterial pressure and the PCWP is 24. Cardiac after pause, how much?
4.3.
4.3. So the PVR should be greater than 5. How much is the PVR? 6.28. Correct. 6.28. Okay. So it's a typically a combined pre and post capillary pulmonary hypertension secondary to heart failure because of the significant reduction in left ventricular ejection fraction. So the final diagnosis is a HIF-RAF, heart failure with reduced left ventricular ejection fraction. So now from the main screen you can see because the lung sheath with a 8.5 French of the diameter. So the next step is we will use a PADN catheter to directly to perform pulmonary denervation. So how big is the pulmonary artery diameter?
32.
32.
Yeah.
So usually we will define the diameter ratio of PADN catheter to the main trunk of pulmonary artery at 1.1 to 1.221. So the optimal diameter of PADN catheter will be 35 millimeters. So this is a PADN catheter with 10 electrodes pre-mounted on the distal circular ring. So now you can see the angiography. So I have put the catheter into the lung sheath. So I think now you can see the distribution of 10 electrodes. And also once the electrodes were released from lung sheath, simultaneously I need to slightly pull back the lung sheath and to push the PADN catheter out of the lung sheath. So right now you can see the distal circular ring of PADN catheter just localized at the orifice of the right branch. So from the figure, you can see the distal electrode is number 1. The more proximal one is number 10. So we can start from number 2. Start. So from the camera image, I think you can see the main screen of the generator. It start from 0 temperature and with the gradual reduction of impedance. So right now the temperature is increasing not slowly. The target optimal temperature for ablation is 50 degrees. So now it's close to 47, 49. 问问病人有没有胸痛？没有。Okay. So I can feel very strong impulsation from the pulmonary during the procedure because we are using number 2 electrodes, which is as a distal part of the catheter. So how much is the temperature right now? 51, 49, so almost 50, right? 哪一个是温度？对。So also generate has a automatic function to terminate the ablation once the temperature is greater than 50 degrees. So now the effective ablation time is the 75 seconds. So how to define the effective time for ablation, Dr. Zhang Hang?
150 seconds.
So usually we calculate the effective ablation time from the timing point when the local temperature is greater than 50. So usually the machine will need at least 20 seconds to achieve the local temperature greater than 50 degrees. So I think it's fine. Right now it's 112, right? Stop, why stop? Huh?
Impedance
Impedance is too low. Okay. So I think we have finished the first round of ablation. So even the launches is pretty large with the lumen, but because the PADN case is almost 7.5 French, so it means that there is a very small space to measure pressure from launches, but we can try because before the procedure, so the mean pulmonary arterial pressure was 47. Okay, so let's see how much change of mean pulmonary arterial pressure. So right now the mean pressure is 38 to 39. It looks good. Looks good. How much is the temperature? Even 52.
Yes.
Why? Because they designed the upper limit of temperature is 50. So once the temperature is greater than 50, so the machine will automatically terminate the ablation. So the procedure is very safe because the patient has the combined pre and post-capillary pulmonary hypertension. So once we get a slight reduction of pulmonary arterial pressure, I think there will be slight rebound increase of the PCWP or even okay, finish it, right? Okay. So we have finished the ablation at site A and site B. Now I think we need to slightly rotate the catheter to get the ablation at the site C. From the pressure line, we have finished the first 4 rounds of ablation. So right now, systolic pressure decreased to 60, I think less than 70. So after finish the ablation, so from the image you can see, I very gently, very carefully remove the electro catheter, PADN catheter into the lunges. So the remaining step will be very, very simple to see how much change of the 导管拿走. So this is not a necessary step to measure the change of pulmonary arterial pressure. How much is the pressure? I feel it's reduced much more, right?
Yes.
Before the procedure, mean pressure is 47. Right now is varied from 42 to 45. But significantly, the systolic pressure decreased much more. How much is the systolic pressure before the procedure?
刚才那个纸 82.
82. So the systolic pressure is much high. But mean pressure only reduced by 2 millimeter mercury. But systolic pressure reduced by 13 millimeter mercury. It's amazing. So guys online, I think we have finished the whole procedure of pulmonary arterial denervation. For this case, with the combined pre and post capillary pulmonary hypertension, we showed the standard procedure, standard steps of the how to do the PADN. The procedure is very easy because once we have finished all the angiography, measurement of hemodynamics, we only need to take 10 to 12 minutes to finish the ablation at the four sites. Thank you. Goodbye.